Good morning, everyone. It's my great pleasure to moderate next session. As we all know, we have a really strong data according to imaging-guided PCI. These techniques, they save lives, but unfortunately the penetration in Europe is quite low. And that's why we need to take something from people that they're really experienced, and Asian people, Asian physicians, they're using almost 100% of their cases imaging. That's why it's my great pleasure to ask Dr. Mampet Mankau from Thailand as an expert in imaging to share Asian perspective.
Thank you very much. Good morning, everyone. First of all, I would like to thank the organizing committee, especially my good friend Nikolai, for your kind invitation. It's my pleasure to be here to talk about the imaging-guided PCI from the Asian perspective. So first, let me show you the difference in the CAD phenotype in Asian and in the European people. So if you look at the calcium score in the East Asian patient and the Caucasian, you can see that both in men and women, the Caucasian patient have a more choline calcium score than the East Asian people. But in the Asian, there is also the difference between the East Asian and the South Asian patient as well. The East Asian means China, Japan, Korea, and Taiwan, and the South Asian means India, Pakistan, Bangladesh. So if you compare East Asian, South Asian to the Caucasian, the East Asian exhibit lower choline calcification with the lower non-calcified plaque compared with the Caucasian on the CT, with no difference in the luminal stenosis. But in contrast, the South Asian people exhibit similar higher choline calcification with the higher luminal stenosis and smaller luminal dimension and more high-risk non-calcified plaque than the Caucasian. If you look at the intravascular imaging usage rate, you can see that there is a significant difference in using the intravascular imaging according to the country. In Asian, especially Japan, they use the intravascular imaging around 96%. But in European country, the usage rate is around 10%. And what is the barrier to use of intravascular imaging? In Europe, the reason include the cost and the lack of reimbursement and the time constraint. And but in Japan, you can see that there is a fewer barrier. Imaging is well integrated into the standard practice. And what about the benefit of using intravascular imaging in the Asian patient? This is the registry from the Japan, including 8,000 patients. You can see that the IVAS-guided PCI can decrease the death and the need for the CBG compared to the angiographic guided or PCI. And another topic I would like to mention is the style of the imaging utilization in Asia, especially in Japan. So the practical use of imaging in Asia, in the routine case, we use the general IVAS. General IVAS means to study the plaque characteristic, to measure the minimal lumen diameter, stent sizing, check the stent optimization, the MSA, the edge dissection. But for the complex case, there is more trend to use the applied IVAS in the practice. Applied IVAS means you use the I was guided for the wiring, both real-time I was guided, or you use the combination of the I was imaging and the angiogram and I was guided or CTO. Let me show you the example of the real-time I was guided wiring. This is the TDADR, the tip detection, antigrade dissection, and reentry. So let me show you this, explain you this example. So this is the, sorry. So this is the case that the guide wire, the first guide wire went into the subintima. So how to re-enter into the distal true lumen? In this situation, you can put the IVAS into the subintimal space and put the second guide wire in. So here is the IVAS in the subintimal space. This is the distal true lumen, is your target. So with the IVAS imaging, you move the IVAS catheter back and forth, back and forth, back and forth. You can appreciate the position of the shaft of your second guide wire and the direction of the tip of the guide wire. So with back and forth movement, you know the shaft and tip direction. So like in this example, you can, you know that if you move the tip counterclockwise a little bit, you can get the tip perpendicular to the distal true lumen and then puncture it. So with this manner, you know that you have to move the guide wire clockwise or counterclockwise direction and how far you have to move. And with this, you can get the guide wire in the distal true lumen. Let me show you this example. This is the example of the case of the non-STEMI. It's not CTO, but this patient went to an inexperienced operator, my ex-fellow, but and he didn't recognize that he advanced the guide wire in the subintimal space, and he already put the stent in. And this is the IVAS. Sorry. And this is the IVAS. So you can see that the guide wire and the IVAS is in the subintima, and up to the edge of the stent. So that's why there is no flow at the distal part of the vessel at all. So how to bail out this? So in this case, I put the IVAS catheter in the subintimal space and another guide wire, the second guide wire, and do the TDADR. So with this real-time IVAS guidance, I know the direction that I have to move the guide wire to, and then I can get success to put the second guide wire in the distal true lumen and get the distal flow. And another example is the combination of the IVAS image and the angiogram. This is the instant CTO, the ISR CTO of the left circumflex. And my boss, he advanced the guide wire distally, but the guide wire went into the subintima, and he failed to do the re-entry after several attempts. So in this case, we put the IVAS in the subintimal space, and with this, we know that this is the IVAS in the subintimal space. This is the true lumen, is the target, and this is the pericardium. So with the knowledge of the anatomy, you know that the left circumflex run into the atrioventricular groove. So if the pericardial space is at 12 o'clock, on the right side, 3 o'clock is the ventricular side, and on the left side, the 9 o'clock direction is the atrial side. So you know that in this situation, the true lumen is more on the ventricular side compared to the IVAS catheter. So the direction that you have to point your second guide wire to is more ventricular side than the IVAS catheter, so which means this side. So with this information, he can get the successful re-entry only in one attempt after knowing this information. And but with this, you have to have the knowledge about the anatomy of the branching and the pericardium and the IVAS correlation. I don't have time to explain this, but I can give you the idea about this. Another example is the IVAS guided CTO PCI. You can use the IVAS for CTO PCI both in antegrade and retrograde. Antegrade, you can use IVAS for proximal cap identification and puncture, and then confirm the guide wire position after puncture. And for the retrograde, you can use IVAS to assist the reverse cart and monitor the retrograde guide wire. Let me show you this example. This is the CTO of the mid-LAD. And in this case, we have the problem about the ambiguous of the proximal cap because we were not sure that the proximal cap is here or here where we have to puncture. So in this case, I put the IVAS in the septal branch and then pull back. And you can see the proximal stump coming here. So with this, we do the mapping with the NGO. So this is the point that we see the proximal cap. So with this, we know that we have to puncture here. The proximal cap is here, not here. So we have to puncture here. So I puncture with the Gaia, and then I do I was to check again, and you can see that the guide wire is in the center of the intimal plaque. So if the guide wire is in the center, there is a high chance that your guide wire is in the intimal plaque. But if the guide wire is at the periphery, it's high chance that your guide wire is in the subintimal. So in this case, guide wire is in the center. So I advance the guide wire further, but unfortunately at the mid part of at the distal part of the CTO, the guide wire went into the subintima. So I switched to the retrograde approach from the septal to septal and advance the retrograde guide wire. But I failed to do the direct retrograde while crossing. So I decided to do the reverse cart with the IVAS guidance. I use a small balloon to dilate antegradely, put the IVAS in, and from the IVAS information, you can know the correlation of the antegrade and retrograde guide wire. So here and here, the retrograde guide wire is in the plaque, and the antegrade guide wire is in the subintima. Here, both retrograde and antegrade guide wire are in the subintimal space. So you know that if the antegrade and retrograde guide wire both are in the subintimal space, it's easy to make the connection because subintimal space is loose. But if the retrograde guide wire is in the plaque and antegrade is in the subintima, it's difficult to make the connection. So with this information, I decided to do the reverse cart at this point because it's easiest to make a connection. And then I can make connection and advance the retrograde guide wire, and I use the IVAS to monitor in the left main that my retrograde guide wire is in the proximal true lumen, not in the subintimal space before entering the guide catheter. And this is the final result. Let me show you another short example of the CT guidance for the procedure planning. This is the proximal LAD CTO, and you can see that the distal target is poorly seen, even from the collateral injection. Cannot see the distal to lumen. So the first operator failed because he didn't know the distal target. So when he advanced the guide wire, it went into the subintima. It went to somewhere because of he didn't know the target. So we stopped, and I review the CT again, and I saw that there is a one conus branch here, and this conus branch supply the mid part of the LAD, the distal target for the CTO. And the first operator, he missed this conus branch because the JR catheter went too deep into the RCA. So he missed this conus branch. So with this information, and next time I put the micro catheter in this conus branch and do the selective tip injection from the conus branch. So with this, you can see the distal target. So with this information, when you see the distal target, it's easy to advance the antegrade guide wire into the distal to lumen, and you can get a success. So, ladies and gentlemen, there is a widespread adoption of the imaging across Asia, particularly in Japan, contrasting with the European and North American practice pattern. And with this high adoption, is translated into the routine imaging guide PCI in the majority of the case. And in the complex case, such as CTO lesion, there is more trend to use the apply IWAS guidance to guide and also the CT to guide the precision intervention and optimize the outcome. Thank you for your attention.
Congratulations for your great talk. Any questions from the audience? No. I have one question because, as I said before, the penetration of IVUS, and you show brilliantly this in Europe is really low. And of course, all the time we are speaking about the money and the reimbursement. Nowadays, in our country, we have quite good reimbursement for this technology, but still, we don't have high penetration and of these technologies. In practical point of view, what is your suggestions, your advice, how to increase the rate of use of imaging?
I think that it depends on the barrier in each country as well. So if you have the problem about the reimbursement, it's a problem that you have to talk and to deal with the government. But for the usage, I mean, in the doctor's view, I think one barrier is the familiarity and the knowledge how to use and how to apply. So I think the educational program is helpful, and you start with the routine case, and then after that, when you have a more imaging interpretation skill, you can apply it in every step of your procedure. So I think knowledge and education is very important. But I have to add that the high usage rate is particularly in Japan. But in the other part of the Asia, such as in Southeast Asia, I come from Southeast Asia. Southeast Asia means Thailand, Malaysia, Singapore, in Indonesia. The average usage rate is 51%. With I was in 54% and OCT 46%. So it's not as high as Japan. Japan is a special place.
And I got a very short question. You showed us very brilliant application of IVUS in CTOs, and I'm just wondering, is the using of IVUS in these complex procedures guarantee a procedure of success, or there are some cases whenever you use IVUS and you cannot succeed in opening the vessel in CTO?
Yeah, I'm sorry again.
what is the percentage of unsuccessful procedures whenever you use IVUS, or it's 100% successful?
Oh, I see, I see. So it's not 100%, but it's increased very much the success rate. So let me estimate it. I think if you use IVUS guide or PCI for the CTO, I think the success rate should be around 80 to 90%. But if you fail, it happens sometimes you have to go retrograde or you have to use another option, like in my last case, stop and review everything, review the CT, review other information.
Yeah, I think the ability to stop is very important for intervention cardiologists in certain subsets. Okay, thank you.
Thank you very much. And